This season of the Breech Birth podcast will be a little different. I'll be speaking with researchers, midwives, and obstetricians working within the breech birth space, bringing additional perspectives, knowledge, and evidence-based research to you, the listener. I hope you enjoy these conversations. Hi, Whitney Pinger. Welcome to the podcast.
Thank you so much. Happy to be here.
Before we jump into your questions, would you mind sharing a short bio about yourself, your background, how much you're involved with breech, what you're doing now, what you've done in the past?
Sure. I am a California native. I'm a fourth generation Californian. I was raised on a beach in icy Pacific Northlands of California and started my life as a midwife as a 3-year-old when I was first called a midwife when I would carry the baby fish back to the ocean. On the Pacific coast, we have viviparous surf perch, which are fish that give birth to live young. And when the fishermen would catch them, they would squeeze the mother's belly and they would drop into my hands, and the fisherman would say, "Okay, you're the midwife, carry them back to the water." So that's the first time I heard the word midwife. And I feel like ever since then, I've sort of been a midwife. I've been a midwife for life. You know, you've always heard that midwifery chooses you. I think I was absolutely chosen. And I just started studying midwifery at the age of 10. I started studying midwives. I read a Life magazine about Maud Callan, who's a grand South Carolina midwife who was described as brave, smart, and heroic. And I wanted to be brave, smart, and heroic my whole life. So I followed her. I still give out the Maud Callan Award in my practice. I studied with Ina May Gaskin, spiritual midwifery, Michelle O'Daunt, birth in the squatting position. I was part of the feminist women's healthcare movement, which did home birth, and not only home birth in the 70s and the 80s, but radical home birth, VBAC home birth, breech home birth, twin home birth. And I worked as an apprentice in that setting for many years before I went to midwifery school. I graduated from UC Berkeley and I went immediately to midwifery school at Yale, which was sort of an unexpected journey for me. I never expected to get in, but I did. And it turned out that I was like an expert on normal physiologic birth and no one else was. So even as a student, I was able to talk to people about intermittent auscultation and delayed cord clamping and breech birth and VBAC and skin-to-skin contact, all the things that us in the community birth setting are experts in, but that wasn't being done in the 70s and the 80s as we watched the cesarean delivery rates really start to rise in the time. And at the same time, I got bit by the science bug. Like I loved the science of obstetrics and midwifery and health and wellness. And once the Cochrane collaboration came along in the early 90s, I started really zeroing in on what we called then evidence-based practice and developed a practice based on evidence-based practice because all of Cochrane's earliest reviews of obstetrical practices all were allied with nursing and midwifery strategies. Okay, keeping women upright and mobile, keeping women food and fluids, not continuously monitoring the fetal heart rate. This is all so well known in the scientific evidence, but none of the providers seem to know any of it. So my practice from that point, since those early 90s, so for the last 30 years has been what I call wisdom midwifery. I started something called the Wisdom Pilot Project for normal birth and cesarean prevention. And in that practice, I combined evidence-based strategies with innovative midwifery-led strategies and combined the science, the art, and heart of midwifery into my practice and was able to reach the lowest cesarean delivery rates, highest VBAC success rate, do vaginal breech birth, do delayed cord clamping, do hydrotherapy, water birth in hospital settings. And I spent 35 years of my career as a zealot in academic medical centers, just creating spaces that people wanted to give birth in, that were collaborative with my physician and nursing, anesthesia, and NICU colleagues, but that embraced the heart and the art and the science of midwifery to lead to these great outcomes and really high scores in patient satisfaction, client satisfaction. So that's sort of what I did for my whole career. And breech has always been a part of my career, just because when I started training in the 70s, the 80s, the 90s, everyone did breeches, right? So all through my midwifery apprenticeships, all through my training at Yale, in the years after I trained at Yale, I worked with 3 amazing obstetricians at a level 1 hospital. And they all did breeches, and I learned so much about breech from them. And then 2000s come along, and actually I started seeing it in the 1990s. Like, I started feeling it and seeing it, and like not being able to have colleagues that were willing to work with me for vaginal breech birth, and midwives being told you can't do vaginal breech birth, and laws changing and all these things. But I continued to offer it as a part of the wisdom pilot project for normal birth and cesarean prevention, so that even though breech is only 3% of the population, whereas women who've had previous C-sections are like 40% of the population, 35% of the population, we can have a much higher impact on cesarean prevention by helping and having the best strategies and the best clinical care to support VBAC. But I always continued to offer breech. My last 10 years in the academic world, I led a midwifery service at the George Washington University, and I was lucky coincidentally, so graced to be able to work with so many doctors who were willing to support breech birth, even in the shadow of the Hannah trial. And so the chair of the department, the vice chair of the department, and many of my physician colleagues there were total supporters of vaginal breech. And so we were able to start what we call the GW Vaginal Breech Initiative. Motivated clients who had gone through an intensive informed consenting process and counseling and met specific antepartum and intrapartum criteria. And we offered vaginal breech. And in my tenure there, we had 49 midwifery-led vaginal breech births. And the initiative has continued even in my absence, that my colleagues, Amr Madkour and Catherine Marco, continue to lead that initiative at GW. And they are close to probably 100 breech births now in that initiative. So that's super impressive. And I think that GW was the first academic medical center to do that. And I'm super proud of that as a legacy of the Wisdom pilot. Yeah. And I left academic medicine. Coincidentally, I had planned my departure, but I didn't know it would be during the pandemic. So I literally, my last day was April 30th, 2020. And I thought I had promised myself I would give myself a year off of clinical practice, but it was the pandemic, and all my clients from GW were leaving the hospital and going into the home environment. And so I went right back into clinical practice, serving women in the home environment in a birth center, both a home and birth center practice called Birth Care and Women's Health in Virginia. I did that for several years. And then I started teaching for Breech Without Borders. I have one of my close midwifery friends and colleagues, Christine Loria, was working with Breech Without Borders. I'd known Rixa since she started Breech Without Borders in 2017, because she obviously reached out to us because of our work at GW. I have a very small little chapter in her book about the GW Breech Initiative. And they reached out to me, and I tried it and I loved it. And so the last 2 years I've been working for Breech Without Borders. So teaching vaginal breech birth and studying with scientists and clinicians from all over the world. We come together once a year in Nice, France, and just get insights from each other. We have an ongoing group thread where we're just immersed fully in breech birth. So I'm fully immersed currently in the more didactic, scientific teaching aspects of breech birth. I'm not attending breeches clinically now. And that's sort of a long-winded way of telling you about myself.
I love it, fascinated. And have you got a biography? Because I would be interested in reading it.
Nope, don't have a biography. Very busy teaching breech birth. But there is a movie, there's a really interesting movie that's not well known. It's called Mama Sherpas. It was directed by a woman who was a client of mine. It's called Mama Sherpas, and it was co-produced by Ricky Lake. And it's a really good story in that it features 5 midwifery services in America, and it features GW midwifery. So that gives a little bit of flavor about what we did there and the magic that we were able to have there in terms of developing a collaborative model of care that I believe should be offered to every human being in the world. You know, doctors and midwives working together as expert and equal partners with different skill sets to meet the diverse needs of our clients. So it's there on the web somewhere.
Cool. I'll be interested in looking at that. Thank you. All right, let's jump into the questions. So you've shared a little bit around your experience so far already. Off the top of your head, how many breech singleton births have you attended?
Somewhere between 200 and 300. And that's not as the primary attendant. That's also just as an observer or as a support person. I was in the business of teaching residents and teaching midwifery and medical students. So a lot of times we would be back, just standing by, but because the volume, only 3% of pregnancies are breech, and only about half of those people want to try a vaginal breech. Over the course of my career, I don't know, probably 200 to 300.
Yeah. I love how some of the midwives I've interviewed, a lot of like, oh, only like 100, 200.
But you're talking about an almost 45-year career, right? And I've been lucky. I believe me, when I was practicing clinically, I
Yeah.
would be in at every breech birth I possibly could because the learning was so deep. And I truly believe that you can't ever be an expert. I mean, I don't think you can be an expert in birth, believe me, but especially in breech birth, there is no expertise in breech birth. You can be a willing partner who's taken specific training on how to most safely deliver a breech baby, but because it's not common, I don't think of it as a normal situation. I have never been at a triplet birth, so I know Christine, and I get to hear about her pursuit of that. And I've been at lots and lots of twin births and
Yeah.
worked with that second twin. I've done breech twins. We had a couple cases of breech twins at GW. Most of our cases were vertex breech. GW fully in the training of breech extraction, teaching our residents how to do breech extractions and everything. In forceps, we teach our residents, the forceps is still trained at GW as well. And we think of GW as being sort of a center of excellence for forceps delivery. So I've attended dozens and dozens of sets of twins, but no triplets.
What is the most common breech presentation that you've witnessed in your practice?
Want it to be the frank breech, but I think that dropped foot breeches, and frank breeches, they're about 50-50. So if I had to say the most common, I would say right sacrum anterior frank breech, because I tend to see most breeches. I feel like more breeches come from the right than they do from the left, from the maternal right than they do from the left. That's just been my experience. And I think I've probably seen more franks rather than completes or incompletes, but I've seen a lot of both of them.
Yeah. What's the most unusual situation that you've witnessed at a breech birth?
I could tell a story that, I mean, there's so many, but one unusual thing was we had a home birth transfer from one of our home birth midwives in Washington who'd been laboring for a couple of days in, prodromal labor with a client and hadn't checked her. And when they were talking about transfer after 2 or 3 days, I don't remember exactly what the details were. They were talking about transfer and she asked if she could check. And she did check and it was a breech. And so it was a prima gravida breech home birth situation. That midwife didn't feel comfortable, once it was a breech and brought her right in. And I was coming on that morning. It was a Saturday morning. And the attending that admitted her during the night was on our breech team, but the attending coming on in the morning was not on the breech team. But I was coming on in the morning and I was one of the leaders of the breech team. So at GW, we always tried to have 2 members of the breech team at each delivery. Ideally a midwife and a physician, but not always. Sometimes it would be 2 physicians, but not 2 midwives. Always had to have at least 1 physician. And the woman was unclear what she was going to do. She didn't know what she wanted to do. It was all new and surprising. And then there was uncertainty about whether we could get a breech provider even in. And then we'd had this whole consenting process that we like to do in the last couple weeks of pregnancy. And of course, she didn't get that. So I'm busy trying to consent her and help her get admitted and oriented to a home birth transfer. And nothing was really happening. She wasn't barely contracting during all of this when we were making all these arrangements. And I was able to find one of my colleagues, one of my dearest colleagues, who was at brunch but was willing to come in once she got towards pushing. And I just said, "Could I just spend some time alone with you so we can just kind of quiet down and you can think about what you want to do?" And so we spent some time together in the bathroom. And after that, I examined her and did a very gentle sweep of her cervix just so I could really get a good feeling of what was the dynamics were in the pelvis. And literally she kicked into right active labor and had a baby in under 2 hours. And she felt safe. She got there, she got safe, everything got settled, and we had a baby. And it was really a beautiful
Nice.
experience. And feel very happy for that family.
Yeah.
Yeah, and often in that setting when we hadn't gone through a consenting process, there were members of our breech team that wouldn't want to do it because they hadn't gotten an ultrasound at term and they hadn't gone through our consenting process. We were really focused on the spontaneous breeches that we'd gotten through our process. But this was an unusual situation. And we did have unusual situations. Another thing, one morning I came on and there was someone laboring in the tub. And when I asked the student what her exam had been when she put her in the tub, she said 70 and -3. And I'm like, prima gravida, 70 and -3? That doesn't. Is it a breech? And she said, no. And I just examined her and sure enough, she was breech. And so she was a prima gravida. She'd been in our practice. She was fully dilated and getting ready to push at that point. She was breech. I asked her to stand up and I just put my face next to hers and I just asked her what she thought she wanted to do. I was again in a situation where I was a breech provider, but the attending was not. And she said, well, I was breech. I was born on the farm. And I was like, oh, okay. I guess we're going to have a breech. I better find someone else to come in. And we did. We got her safely delivered.
Wow.
So yeah, we did a lot of really beautiful things and a lot of beautiful planned vaginal, including VBACs, footlings, and not footlings, but dropped foot breeches. So, yeah.
Yeah, that's my next question, actually. Could you please define a footling breech as opposed to a complete or incomplete?
That's
with a
very
dropped foot?
misunderstood, Sasha. People see a foot at the introitus or a foot coming out of the vagina, and they think it's a footling breech. And so a footling breech means that the leg is straight so that the hip is extended and not flexed. But a term baby, really any baby over 34 weeks, doesn't have the space to be a vertical human. It only has the space to be in there and have its hip flexed. So the misunderstanding with footling breech or incomplete breech or dropped foot breech is that people think it's a footling because of definition of a footling is when the hip is extended and the baby is vertical. And in that situation, and that can only happen in preterm babies, and in that situation, there's a risk of the head being larger than the hips in the body. And so that's a case where you might get what we call that cervical head entrapment if the baby is under 32 weeks, so small, and the hips are smaller than the head. So that's what a footling breech is. But people who come in with feet coming out of the vagina are often said, oh, it's a footling breech. We have to go to the operating room. Okay. But those are not footling breeches. Those are what we call drop foot breech. That's when the baby's in like crisscross applesauce or has one leg down and one leg up. And those babies are just coming. They're just coming. That's a normal position. Actually, the diameter of the complete breech is actually larger than a head. So we know if we get that complete breech through, then we're going to get the head through. The thing about dropped foot breeches is that they can take a little bit longer to do their rotational maneuvers, just because there's often, if there's feet and legs up, then sometimes there's arms up. So we always are mindful with complete or incomplete breech that the maneuvers may present a little bit differently and might take a little bit longer, but we still want to have forward momentum. You can even sometimes see a cord. Sometimes when it's a footling, dropped foot breech or an incomplete breech, the cord can come down. And as long as the heart rate is fine, that's still a safe situation. But there is confusion about that. And people don't like it. People also don't like it when the feet become very swollen and purple. People don't like it when the scrotum becomes very purple and swollen. They think that there's something wrong, but that's very normal. So if there's one thing I can say to your listeners, it's a normal variation to have a dropped foot, complete or incomplete breech. If you have a term baby, those feet may be purple and swollen. Scrotum and labia may also be purple and swollen, and it's a variation of normal. Yeah, but it's hard. It's really hard for people who don't have experience to not be afraid of that.
Yeah.
It's very hard, and we understand that. But that's actually one of the amazing roles of people who've taken courses and understand that, or even listen to your podcast, is they can be the voice of reason in a room. So even if you're a doula and you understand that concept, a doula can be a voice of reason in a room that's going crazy and going to open the OR because they think it's a footling breech. It's not a footling breech.
Okay, so another question from our listeners. How common is it for breech babies to need or receive oxygen at birth? And can you explain why this happens?
Well, What's pretty well known is that the 1-minute APGAR scores of babies who are born breech can be lower than their vertex counterparts. And that has to do with the journey through the pelvis and the umbilical cord. If it's tangled in any way around the body or around the neck, that there can be compression on the umbilical cord. While the 1-minute APGAR is known to be lower in breech babies, not always, but often, the 5-minute APGARs are generally equivalent if the baby is stabilized, stimulated, and even resuscitated with the cord intact. So babies who are born breech, we always recommend not clamping and cutting the umbilical cord until the baby has fully breathed and stabilized itself. So that's a core practice. We think of the delayed cord clamping for all babies as a fundamental human right. And I've been a zealot of advocating delayed cord clamping for all babies, but especially for the breeches.
Is that something that was supported at the GW Centre for breech?
Yes.
Yeah, amazing.
Yes.
And so if baby
Yes.
needed resuscitation, they just kept baby attached?
Well, resuscitation is different from stimulation and stabilization, right? Babies are stimulated with the cord intact, stabilized with the cord intact. We would sometimes give what we call birthday breaths with the cord intact. If a baby needed a full-on resuscitation, generally that's different. And then the cord would be milked and clamped and cut and passed to the team.
All right. Could you please explain head entrapment or head deflection, so the difference between those, and in reference to a breech birth, and term versus preterm, how common it is? Because I think head entrapment gets mislabeled with head deflection.
Yeah, so we've touched on that a little bit earlier when we talked about the full-term babies and the preterm babies. Cervical head entrapment is when a baby whose hips and body are thinner than the head, that those parts can leave the uterus and the head can get trapped by the cervix because the cervix isn't fully open. That's what cervical head entrapment is. And in that situation, it generally occurs only in preterm babies. And in that situation, you would need to use pretty serious maneuvers to get that cervix to release, including the use of nitroglycerin and even some incisions to help release that head. That's very different from a deflexed head, which is often confused with head entrapment. A deflexed head, so the baby's head enters in the transverse diameter in the inlet, but it has to rotate into the AP position to get into the mid-pelvis and then stay in that position to come out of the outlet. And a baby's head who's looking up or whose chin is up rather than chin flexed to the chest can have a harder time, one, making that maneuver into the mid-pelvis, but two, coming through that pelvis because the diameter is wider. I can't tell you how frequently that happens. Rixa probably has the best data on that because we do have a video analysis of over 200 births. So I'm sure she has some kind of a number, but we know that there are maneuvers that will help bring a deflexed head through the pelvis. And the most common one is a chest press. If you push on the chest, the baby looks down and it causes flexion of the baby's head to roll through that mid and outlet pelvis. There are also other maneuvers that we use to release a head, including we can put our hand in sometimes if we need to. We can use fingers in the rectum to help release a head that's fully deflexed. But what we say is that if you're seeing any part of the head, the chin or lips, that head is in the outlet. And you can get that head through maternal efforts, position changes, and sometimes that chest press. If you're not seeing chin or lips, then sometimes you might need to add another maneuver in addition to maternal effort, chest press, that you might have to use another maneuver.
Yeah, perfect. Thank you. Have you witnessed head entrapment now that we've defined between the two?
On a pretermer?
Yeah.
On the cervical head entrapment? Absolutely.
Yeah.
Yeah.
And how was that managed? What did that look like?
If you have a true cervical head entrapment, you either use nitroglycerin and that helps relax the uterus and the head can come out, or you cut incisions. There's incisions that you cut at 10 o'clock and 2 o'clock on the cervix to help the baby be released.
Yeah. Perfect. Thank you.
I've also seen deflexed heads, which is often confused with head entrapment and used maneuvers to get those heads. There is another kind of a obstruction that is also confused sometimes, and that's when there's what we call a inlet obstruction or a CPD, a cephalopelvic disproportion at the inlet. And that's when the bodies come through, but the head is either elongated or it could be hydrocephaly, it could be dolichocephaly, but there's times that the head doesn't fit easily into the transverse diameter of the pelvis and it tries a bunch of different ways and there can be an obstruction there, and that takes specific maneuvers to help release.
Yeah. Perfect. Thank you. Do you have any experience supporting women with a known bicornuate uterus? And if so, what have you observed and what should these women be aware of if choosing a vaginal breech birth?
Well, I think that bicornuate uterus is known to be one of the reasons that babies get into a breech position in a bicornuate uterus. And when labor begins spontaneously and progresses, I haven't seen any differences in how those babies do. I have had some cases where labor didn't progress spontaneously with a bicornuate uterus and the baby didn't come down. And in those situations, it's hard to know what was going on. And in one specific situation I'm thinking of, we just went for cesarean delivery.
Yeah.
But that bicornuate uterus is a known thing for supporting a baby to be in a breech position.
You've touched on cord prolapse a little bit before. Is cord prolapse in breech a problem like it is in cephalic birth?
Well, I try not to think of anything as a problem. I kind of think of it as a condition or an outcome. And a cord prolapse is always an unexpected outcome. We consider that an unexpected outcome, something that we don't really like to see. But it doesn't carry the same weight in a breech birth because the head isn't coming until the very end, whereas in the cephalic birth, there can be major compression as the baby comes through the pelvis with the head against the cord. So what we say with breech birth is that the umbilical cord can present, and as long as the heart rate is stable and you're seeing good progress, that you can continue the birth.
Perfect. From your experience, is prom more common in breech presentation?
In my experience, what I would say is if there was one pattern that I saw most commonly in breech was that sometime between 37 and 39 weeks, the bag would break and people would go into spontaneous labor and have their baby. So is it more common? I would be interested to hear what Rixa found in her video analysis or in her data analysis, because I don't know the answer to that scientifically, but it makes a lot of sense that the bag breaks and then labor would start up.
Yeah, it's been interesting interviewing a lot of women on this podcast and the amount that have had their waters break before labor started. So I'm seeing that in the stories that I'm hearing, definitely.
Yeah, and it's definitely what I saw most frequently happen in the planned vaginal breaches that I have attended. And I usually counsel people, that what we see frequently is that your bag will break somewhere between 37 and a half weeks and 39 and a half weeks. And ideally, you'll go right into labor. That would be the ideal. If you don't go right into labor, we'll figure out what we're going to do then. But the hope is that you'll go right into labor.
Side question, at the GW Centre, will they offer an induction for a breech presentation? Because I know there's controversy around that. I know some hospitals will and some hospitals
when
won't.
we first started the Breech Initiative, we were all pretty aligned that we weren't going to use Pitocin augmentation or induction, but we had leadership at GW that was fine with using Pitocin for induction or augmentation. And over time, my physician colleagues became, and many of them were already comfortable with it, but it was something that I wasn't comfortable with, that I didn't have experience with. So I was a learner in that situation. And I saw Pitocin used mostly for augmentation. I cannot recall a case of induction for a breech birth, but that doesn't mean it didn't happen. But I can't recall that. And again, it took me time to get comfortable using Pitocin augmentation for breech births. But I had a lot of leadership from my colleagues who felt very comfortable with it, and it really helped us have vaginal breech births.
Yeah. Beautiful. All right. Next question, also from a listener. Are you still likely to progress if baby's foot is presenting in front of their bottom? So I guess this is coming back to that presentation, because you've defined what true a footling is. But I mean, in different countries, like in Australia, when I look at our textbooks, it's defined of what's actually presenting at the cervix is what they label it, when it's not necessarily.
We would expect the same kind of progress. I think, as I said earlier, what I tended to see was that frank breeches progressed more predictably than dropped feet breeches, complete or incomplete.
Could you please explain collaborative care and how this benefits the women you care for?
Yeah, I mean, collaborative care is my passion. The Wisdom Pilot Project for Normal Birth and Cesarean Prevention was a evidence-based collaborative practice with doctors and midwives working side by side as equal and expert partners to meet the needs of women and birthing families. And collaborative care extends beyond midwives and doctors into nursing and doulas and to their families and to our NICU colleagues and to our anesthesia colleagues. Collaborative care is where everyone is working together to support the safest, most client-centered experience for every birthing person. So collaborative care it's a wraparound way of saying, look, we've got a whole team to support you to have the birth that you want. So helping pregnant and birthing people decide what kind of birth they want, that hopefully has happened during the prenatal space. But once active labor is happening, that having everyone on board with supporting whatever the request is. And it sometimes takes us out of our comfort zones, We all practice on a continuum, but I believe in the power of collaborative care, and I've seen the kinds of outcomes that collaborative care can bring. At GW, the midwifery-led caseload in a collaborative model of care, we had a 88% physiologic vaginal birth rate, meaning 88% of our clients delivered without an epidural, upright, mobile, and having their babies. And then the other 12% had epidurals. We had a 77% vaginal breech rate. We had a 92% VBAC success rate. And that can only happen in a collaborative model of care. True collaboration is just where everyone is standing by and supporting the needs of people when they're birthing and to keep them safe. I define labor not by hours, but by patterns. Yeah. And so pattern 1 labor is like labor starts, it doesn't stop, and you have a baby generally within 24 hours. You use evidence-based strategies and supportive care, and you have your baby. And those 65% of the births just are pattern 1 labors. And those are the ones that are great for students and learners and the midwives and the families just to have a great time with. Then there's another percentage, 20 to 25% of people who get pattern 2 labor, which is longer labor. Doesn't mean that there's something wrong. It doesn't mean there's something abnormal, but that it takes longer. There's something going on that's making the labor take a longer time. And, we go through the powers, the passage, the passenger, the pelvis, the psyche, the pain. We try to differentiate and tease out and then make little interventions and adjustments in our science or in our strategies. And then pattern 3 labor, which can happen 10 to 12, 15% of the time, is like complicated labor. Labor starts, it doesn't progress, you get fever, you get meconium, you have abnormal fetal heart rate tracings, you have complications, and the goal in that situation is to have a safe delivery for mother and baby. So in pattern 1, it's independent management for the midwives or the residents. Pattern 2 is there's collaboration. Pattern 3, there may be transfer of care. Does that make sense to you?
Yeah, it's great. I love that. How do you effectively communicate with the doctors and midwives that you work with and or refer to?
Just with loving compassion and gratitude and humility and humbleness and gratitude for being able to work together. Just talking honestly, making sure that we're speaking for our clients and keeping in a place of kindness, being kind. Just got to be kind and communicative.
It's a note for all the practitioners out there listening.
Yeah. Yeah. I mean, I think everyone, when we get into tangles, there's always going to be what we call the scratchy stuff. There's always some scratchy stuff. Acknowledging, We're having a scratchy moment right now. Let's just acknowledge that. Let's take a deep breath. Let's talk about how we're going to manage this in a client-centered, safe way.
Yeah. Well said. Last question. Could you please explain circle of safety?
Well, I think we've already talked about the circle of safety. We are the circle of safety. Sasha, you are creating a circle of safety. The hope is that the whole world is a circle of safety for pregnant and birthing people and their families, because that's the future, right? So creating a circle of safety is keeping things safe logistically, like, is it a safe environment? Do we have what we need? Do we have electricity? Do we have water? Do we have the things we need for a birth? But it's also emotional safety. It's creating a place of emotional safety, because we know that when pregnant women don't feel safe, their hormones are not going to allow them to give birth. There's study after study about that. And Michelle O'Donnell just researched that and advocated for uninterrupted birth spaces, creating that circle of safety for pregnant and birthing people. So the circle of safety is like heart safety between a couple, that it can start there. A woman feeling a sense of safety in her own body, being in a relationship with a couple, having her inner circle, a circle of safety, then having her care providers around that, having the institution around that. So it's like this, it's actually ripples, it's layers of safety that extend out from the heart of the pregnant and birthing person, because that's what has to be at the center.
Amazing. I love it all.
If only in the world, if only every person in the world received this kind of care, which is what we're working towards. That's really what we're working towards.
Is there anything else, any last words of wisdom you want to give to any woman listening now who has a breech baby on board?
I think carrying on with that question of safety is like the only thing that matters is if you feel safe. You have to feel safe in yourself, in your own body, in your partnership, in your family, and with your providers. So when you're choosing your provider, you're choosing the environment that you're going to give it birth in, just think about where you're going to feel the safest, where you're going to feel the most seen, where you're going to feel the most held, because the hope is that labor begins and you just go on this incredible journey and you get a baby surrounded by loving safety.
Perfect. Perfect way to end our interview. Thank you so much, Whitney, for your time and sharing all your wisdom. I feel like you should write a book. I want to read it, and your life experience. I can imagine you've got some incredible stories to share.
Yeah, well, I've been so blessed in my path and in my career as a midwife, and have been guided by so many amazing clients and midwives and physicians and colleagues of all sorts. And it's been a beautiful, beautiful and very adventurous journey. And it continues because I get to keep teaching. And I'm also now delivering my grandchildren, which is a beautiful aspect of my life. I've been to Kenya twice to deliver 2 of my grandchildren. And then I have another grandchild here in California with me. And I've gotten to catch all 3 of my grandchildren so far. And that makes me just, so grateful.
I am currently waiting for my second grandbaby from my daughter. The excitement is building within.
It's very exciting.
Yeah.
It's a aspect of life that I didn't expect would happen in the way it has. And I'm so grateful. Grateful to my children, and I'm grateful to their partners to invite me in, and just feel so blessed.
Beautiful. Well, awesome. Thank you so much again.
See you again. Thank you for your hard work on the Breech podcast. It's so important for people to hear other people's stories. The power of storytelling is what connects us. It's the umbilical cord of connection between the past, the present, and the future. So let's keep going.
Absolutely. The Breech Birth podcast is independently created and produced. If you'd like to support the continuation of this space, you can do so through Buy Me a Coffee. Your support helps keep these stories being shared and accessible to women and families around the world, and you can find the link in the show notes. Thank you for listening to the Breech Birth podcast. These stories matter. They stretch what we think we know and bring voice to experiences that need to be heard. I'm so grateful to our guests who have shared their experiences with us, raw, real, and full of wisdom. If this episode resonated with you, please subscribe and share with others. You can find us on Instagram, Facebook, and YouTube at Breech Birth Podcast. And if you have a breech story to share, I'd love to hear from you. Until next time, may we continue to reclaim the narrative, one story at a time.